distal diagonal to avoid at least compromising the proximal part.
Yeah, we agreed with that. We discussed that earlier,
yeah.
and we thought
because there was, just a comment that there was no need for a wire in the diagonal, which I think it would be taking a little bit more risk of losing this diagonal in case of a black shift. So I still think having a wire in diagonal standby is important rather than just going for a super selective stent implantation distal to the diagonal. I don't know what you comment about that. Would you do that retrospectively with one wire in the LAD alone, or would you?
This particular patient is not the ideal patient, but if you have no osteal lesion, so if you are doing say 0, 0, 0, 1, 0 or 0, 0, 1, so you have a distal, 0, 1, 0, okay? So you have distal main vessel stenosis, osteal side branch, no stenosis. We tend to place only one wire. If you have 0, 1, 1, so you have true bifurcation, you have diagonal osteal stenosis, distal main vessel stenosis, I think you're obliged. Most of the people would put 2 stents. But in this particular case, there was no osteal stenosis in the diagonal branch. No. And I think, although there was a disease a little bit more distal into the LAD, distal in the diagonal, I would think people would probably use 1 wire or 2 wires. Just would be divided, I think.
You said
for me, I would have put 2 stents to start with. I mean,
John,
most of the studies showed that putting a stent in the main artery and only angioplasty in the main branch has a better outcome on the long term than putting 2 stents.
No, I think this is very important. I mean, this is you're putting a point which is so important. This should have been in the beginning, which is the address of simple versus complex PCI, 1 stent versus 2 stent. And I think people have misunderstood and misread the data of, as you know, the Nordic PCI. I don't know if you agree with me, John, or not, but the Nordic PCI and the BBC1 trial that compared 1 stent versus 2 stent, I think is misinterpreted by a lot of people. So it made people take bifurcations very easy, put 1 stent even if you have a major compromise of the side branch, a long lesion. I agree with John when he said that if you put a balloon in this diagonal, he would stent it. And I think that's what I would do. I mean, you cannot leave a compromised diagonal like this with a balloon injuring the endothelium and leave it without a stent. So this 1 stent versus 2 stent from the literature of BBC1 and Nordic PCI, I think personally that it has been misinterpreted by a lot of people who want to do a quick job in and out.
Absolutely. Fully agree.
Okay, just my question regarding this patient who is elderly and diabetic, ex-smoker. We think advanced atherosclerotic, manifestation in his vessels. Now, the FFR, yes, will tell us about the hemodynamic significance about the lesion, but it will not tell us anything about the vulnerability of the plaque to rupture or to progress. So you think, is it enough for FFR to satisfy ourselves that this lesion needs not to be done, or IVAS still has an important role? Thank you.
Yeah, you're right. It's a very good point. But, the medicine is improvement. The research, the science is improving. And what is true this year should be maybe not true in 20 years. So it's true that today we have the FFR to assess functionally a lesion. But it's true that in a diabetic patient, when you look at what's happened in the outcome of this patient, it's not measure the problem of restenosis, stent restenosis. It's a problem of progression of the coronary artery disease on all the parts of the vessel stented or the other vessels. We know this, but how to anticipate, how to look at anticipate the prognosis of the moderate of mild lesion on a vessel. We don't know today. There was a prospect study, etc. We participate to this study, but again, we cannot do IVUS and VH evaluation to all the vessel when we have a patient coming with a single vessel disease and acute coronary syndrome. This is not reasonable in routine practice.
Yeah, not all of the not all of the vessels, but this one is a large diagonal, and you thought that it supply a similar area like that one supplied by the LAD, and apparently it is diseased.
Yes, but you know, particularly in a diabetic patient, we don't know which lesion will give you a poor outcome in the 1, 2, 3, or 4 years. It's not necessarily the lesion which is 70% today. It could be a plaque at 20%. And this was proven in the prospect study. There was some plaque which was really mild plaque. We give plaque rupture in the 1 or 2 year follow-up. And other plaque which were at 50, 60% lesion remain stable. We don't know today, and we have not predictors to do that. So we have to do this today, this tool, with the use of FFR. And the FFR, we know that PCI guided by FFR give you at least similar or better result that PCI guided by angiography. This is the concept. The rest, we cannot extrapolate more. Okay?
Can I add to the...
Maybe we have to conclude, and I will finish the conclusion with a talk on EuroPCR, the news of EuroPCR. It's 5 minutes. It will be very short, not annoying, but there is very new things, and I think it should be interesting for you. First of all, before leaving you, thank you for the 3 panelists. I enjoyed to share this session with you. I hope that this concept of live in the box is interesting. It's a new concept for education. The possibility, I think, to stop the video when you want, to have a distribution, come back to the live. It's, for me, more interesting than the real live demonstration. I know that in a meeting we have to have a good balance between the emotional aspect of the real live and the best education, I think, from the live in the box. Thank you again, Ibrahim, Mohammed, and Hassan, and hope to see you, I'm sure, in Paris. So thank you for all your comments during the session. And what I would like to do is to give you some news concerning PCR. First, this is the preamble of this really short talk, 5 minutes. PCR is dedicated to education in cardiovascular intervention. Really, our goal is to education. This is the first goal. We need to combine interactivity like today, innovation with the new techniques, ethics, and this is very important, to be ethics and to be really free of any conflict, particularly with industry, and try to move to the excellence. PCR aims to energize the scientific community by sharing the knowledge and increasing exchange between peers. And this is important, to share what we have learned. So, first of all, there is a restructuration in PCR. That is to say, I think that there is one more. Oh, okay, this is this one. This is the structure of PCR. We have courses, we have educational solution, we have communication, that is to say editing. Courses, you know EuroPCR, and we will be back in Paris this year. We have started this year Asia PCR with sharing the course with the Sing Live in Singapore. And the new thing will be for 2010, the PCR London Valve, running by Martin Thomas, and we will focus on the problem of percutaneous valve implantation. Education solution, that is say, the goal for the future is to organize some session, small PCR for 50 to 100 people, but with the same philosophy, what we will call the seminars. And the editing, we have the website, PCR Online, and this website is free, and there will be new people now involved in order to really improve the quality of the website, and PCR Publishing with Euro intervention in association with EIPCI, European Association of Percutaneous Coronary Intervention. The restructuration is the following. Jean Marco is now the chairman of the PCR. The chairman of Euro PCR will be William Wins. The chairman of PCR Online will be Alec Vagnon. And the chairman of Asia PCR Sing Live will be chaired by the Professor Ko and Jean. So we come back to Paris this year from 25 to 28 of May, and I hope that you could join us for this new session of EuroPCR. What is new? It's the program was 100% rebuilt. That is to say, compared to 2009, we start from zero again, because regularly we have to renove and to place what we know, the new blood in the system. So we rebuild, and with a bottom-up construction. That is to say, we use the we asked to the different presidents of the working group in the Europe of ESC involved in the EIPCI to give some proposition. And this proposition was shared by and treated by a program committee member. And now we have more than 20 people, with young people now in the program committee member. And at the end, the proposition from the base, the working group, the program committee member, was analyzed by the board of EuroPCR. We have three main tracks this year: coronary and structural heart disease, endovascular disease, and a course for nurse and technicians. Coronary and structural heart disease program, there will be 4 gateways to mirror the life cycle of the device. That is to say, there will be session on innovation, session on techniques, purely techniques on the device, session on clinical outcome, the trial, etc., and session of the evidence, which should be mainly the randomized trial and meta-analysis. There will be more innovation session and innovation incubator. This is totally new for EuroPCR. We will organize some session with a new technology in coronary, structural, and peripheral artery disease. There will be more forum session. We start last year with a forum on bifurcation. There will be more forum session, and really the place to learn from your peers, from the experience for the people. More learning the technique session that we have done today, and there will be more complication also session. Learning the technique, there will be 4 sessions: 1 on bifurcation, 1 on CTO, 1 on multivessel disease, 1 on the TAVI. Complication, 8 thematic sessions. The abstract, we received 700 submissions this year, and this abstract will be given by oral presentation, and there will be poster area with interactive